All right, happy Friday, and first Friday as well for fertility. I'm Dr. Perry. For those of you I haven't met, I'll be talking today about Easter eggs since we're in April and talking about recurrent implantation failure, the immune system. Hey, Tricia, I was just saying that the topic you proposed on reproductive immunology is going to be my first choice and focus for today. So that's going to be a great thing. And anyone with any topics they want to hear about should also post and say something. But I'm going straight into that. In fact, since you are on, let's talk about IVIG, immunology, and how that can affect your fertility. And then I'll just sort of go into a little bit more of um, NK cells, and then I'll get back to the sort of the Easter egg theme for this week. So here's what IVIG is. IVIG is a condition or a series of immunoglobulins. It's basically taking, hey, Trisha, you take people who've had, you take the blood from a ton of people, you take all the immune system and you filter out the immune components, and then you say, okay, we're going to take the immune system of hundreds, if not thousands of people, and then give it to one person. And that's difficult, and it's really expensive. Often it's in the $10,000 a dose range. So obviously that makes a, hey, Jessica, how are you? In terms of things, it can make an enormous cost for things, but then it's very powerful if there is an immune system issue that has sort of come up for people. And so the question is, if we do this, will it improve fertility? And ASRM has come out with an unequivocal, for the most part, no, do not ever take IVIG for things unless it's in a research setting. Because what they showed with the study is you had the odds ratio for pregnancy. Hey, Tadia, how are you? Hey, April. We end up seeing that the odds ratio, or the odds of being pregnant, is 0.9. So by taking it in most settings, especially for recurrent pregnancy loss, you were 3% less likely to be pregnant for having taken it, and at an expense of about $10,000, which insurance doesn't often cover. And so the question is, if it's not really that effective and it's really, really expensive, why on earth are so many people talking about it online and that they've taken it and they've gotten pregnant? Well, an odds ratio of 0.97 doesn't mean that you are markedly less likely to get pregnant. A lot of people got pregnant just would have gotten pregnant no matter what. But why does it resonate? Well, first, we always want something that no one else is doing, or that this can provide hope that no one else has. And IVIG is something most people have not tried because it's so ridiculously expensive. And I think there's a part of us that always wants, oh, it's in our heart, if I try this, this will be what made the difference. And I can understand that, but it's better to channel your energy in something that makes a difference rather than a really expensive placebo. Oh, hey, more people coming on. By the way, I've been, hey, Meredith, hey, Lana, I've been sort of focusing and talking a bit, and you'll see me again. Oh, you guys know, I get distracted, focused on everything for stuff. So then why else would it be there? Well, there are some commercial interests that are very big on promoting IVIG as a therapy for infertility. You're talking about them making $10,000 every time it's used, and you might use it several times over the course of pregnancy. And in some health systems where you can bill it to insurance, that's making them $100,000. That covers a lot of marketing to sort of promote awareness and promote people wanting to use it, when most of the evidence doesn't show that it helps. Hey, Emily, how are you? Looking forward to seeing you. And hey, Angel, also. Okay, great. All kinds of cool people here. So that would be the one thing. So it's hope, it's something different, and there are a lot of people marketing it. At the same time, I think here's the important thing for IVIG. Where there may be some benefit is in people who have some abnormalities of their natural killer cells. That's only 3% of the population. So the likelihood that that is personally affecting you is relatively low. Now, again, some people will torture the data until it confesses. They'll find a way, oh, yeah, you're a little bit abnormal. No, you need something markedly abnormal in order to show benefit. And the reason I'm saying that is just don't put your hope in these fringe, fluke things that are really, really expensive and unlikely to help you. Focus on what does work. But again, if you are that rare exception and that's the right thing for you, then definitely do it. But I would say it's more important to get a good diagnosis and the right diagnosis than to just try something that's fringe just because it hasn't been done before. And again, oh, hey, Candace, how are you? I'm going to just say a quick love. Hey, Heather, lots of love for everyone. Oh, and Vicky, of course, got to love Vicky. Everyone is the love there. Oh, thank you, Lana. Very nice for you. So, okay, now we're on the month of Easter, and so, of course, got to do Easter eggs, for things. And again, if you, hi, Amanda, if you guys have topics you want me to cover today, I'm going to do it. Just, come up with something, type it in. Cynthia Trejo is back there. She's waving. You can't see her. It's kind of interesting. As I was sitting here, I'm noticing there's a painting right behind me for one of our satellites. I would say I not only literally have women behind me, but I have a lot of amazing women that have been supporting me throughout my practice, my career right now, for Cynthia, for Vicky, everyone back in the clinic. I would say anything that's done capably in this world involves having good women behind one. So, have to give credit where it's due for that one. Anyway, let's, thank you, Heather. Hey, Vicky. In terms of what we're looking at for the eggs, so talking about the eggs, what is the ovary? So starting out there, so actually the ovary comes from the Latin for egg or for nut. So apparently our ovaries drive us nuts at times, and sometimes working a lot to get good things that can be difficult. But the question is, how does the ovary work? What are the values of it? And it really does two things. One is it provides DNA for getting pregnant, and the other is it provides the hormones to make the pregnancy possible or sustained. So if you took an egg and fertilized it and had an embryo and just put it straight back in the uterus, it would dissolve, it would break down, it wouldn't be the right synchronization. Yeah.
Juan says premature ovarian failure chances with donor.
Okay, I'll tell you what, I'm going to include that, and that's actually part of my natural flow, and it'll probably be about 5 minutes before I get to that part of talking about eggs. Okay, so for what the egg does, the egg is itself literally surrounded by various cells called granulosa cells that convert male hormone into estrogen. And male hormone often shuts down the ovary so that the eggs are not developing. It keeps you from releasing 20 eggs in a month and ending up with a reality show instead of just one. And because those granulosa cells convert the male hormone into the more female hormone of estrogen, then as a result, it doesn't put on the brakes on the developing egg, because it sort of changes things, even if there's a lot of male hormone that would shut down the other eggs. And that's part of where PCOS comes from, where people have a lot of male hormone and there's no dominant egg that could stop it with a lot of these granulosa cells. And so the estrogen is building up the lining of the uterus so it's ready for a baby to implant or embryo to attach. And it's also what determines the LH surge. When your egg gets big enough and is mature enough and high quality and large, it has an estrogen level that's so high, the brain says, okay, this is ready to be released. I'm going to send a signal, and that's what triggers your LH surge. So at an estrogen level of about 200, 250 picograms per ml, that's when you actually ovulate. So actually your estrogen level that's secreted by the ovaries timing when you release the egg. And that's also important because if you're getting 2 or 3 eggs, you can actually have a higher estrogen level earlier, and you can ovulate earlier than if you had just 1 egg. And that's part of why we're watching and timing things a bit more closely. And sometimes if I see people even getting into the 3 or 4 egg, I might trigger them a little bit earlier for sperm to find the egg than if I saw just 1 egg where you can go a little bit longer. The answer that's always right in medicine is it depends. We're keeping track of that. Just looking at a few things here.
Holyfield would love to hear your thoughts on treatment options for diminished ovarian results.
Okay, so I'll tell you what, since we're getting a lot to that, let's get into DOR and egg donation, what happens with that. Let's just focus on the egg then for that. So again, the egg, normally if you look at the ovary, you'll see at 25, you'll see 12 eggs per ovary, so 25, 30 normally. There's a bit of a range. 30, it's more 10 per ovary, 35, about 8 per ovary, and by 40, you might see 4 per ovary. And so the way I describe these is sort of like job applicants. If you have 20 people showing up for a job, that's the pool you have to draw on for a month for getting pregnant, you're probably going to find a decent one in there. If you have 2 or 1, you're stuck with whom you've got. And so the fewer eggs that you can see in the ovary, the less likely you'll have one that is functional or chromosomally normal. And as a result, if sperm were to find it, the less likely that it was a good one that would actually stick. Now, there's enormous range as to what causes diminished ovarian reserve. In some, it's because some people start out with really few eggs and they just lose eggs at the normal rate, and they just had few to start with. There are women, 5% of women are born with, at birth, have the number of eggs that 5% of women do at 40. So there's an enormous range in where people are. Some also lose their eggs more quickly, end up with, they are exposed to chemotherapy or radiation or environmental toxins, smoking. A quarter pack a day ages your ovary by 1 year, half pack 2 years, a pack a day 3 years, and 2 packs a day 4 years. So the more you smoke, dose response, the older your ovary. Now, even though it's bad for fertility, if you're actively smoking, drops fertility roughly 40% by some studies. It's not just that if you quit and then you're okay. If you were to age a few years, and let's say you're 38 and you are smoking a pack a day, that means your ovary is 41. That's very different from 28 and your ovary is aged to 31. So that's one of the things where toxins can have an effect on ovarian aging. The question then comes, what do you do about it? And so there are really 2 options. Work with the eggs you have or get someone else's, or adoption or child-free living. But again, the goal is, how do you get pregnant yourself? Now, for working with the eggs you have, there are a couple of things. One, you can give medications and recruit them. And you can give letrozole, you can give Clomid, which trick the brain into making more FSH, follicle-stimulating hormone. That's the hormone that gets the ovary to make more eggs. And that works well. But some people don't respond to that medication. And some people, they already have high FSH. If you have really high FSH, so your brain is working really hard to get eggs at all, adding a little bit of letrozole or Clomid may not change that. Plus, often by the time people are running out of eggs, they have lower quality. And that can further, and not just quantity. This is a production line thing. You ovulate your best eggs first in life. Think of it as a game of telephone. You're 2 people down the line, you get the original message. You're 20 people down the line, you have no idea what the first person said. The eggs you ovulate first are the earliest generation copies. The ones you ovulate later are later generation copies, had a chance to accumulate mistakes. And this is why you see more Down syndrome, you see more issues where the DNA is not paired the same way it would be normally as people get older. So coming back to how you make the most. So you can give stimulatory medication and try to get a response. The other thing is you can give supplemental things. And people talk about giving DHEA as supplementation. That's 25 milligrams. People take it 2 to 3 times a day. You don't want to take it more than that, really. There have been people who've taken 25 milligrams 50 times in a day, and they've actually caused adrenal suppression and adrenal crisis and adrenal failure. That's really bad. The other thing is a little bit of DHEA, by the way. There's some limited data suggesting it might help a little bit, and it is a low-cost, low-tech solution, so it could be explored in some circumstances. At the same time, it also has a male hormone precursor, which supposedly is changed to estrogen, It can also make you a little more hairy, and it can make you a little more moody and aggressive. And so when I talk with couples that are sort of on the fringe and they're saying, okay, I'm running out of eggs, can I do anything? I'm willing to try anything that might help. And I say, this is on the fringe or borderline therapy for it. But here's the thing with it. It will make you more hairy. It will make you more mean. But then it also does increase your sexual drive a little bit. And so the husband's there and he's like, well, she is a little bit looking a little more like Sasquatch, but she is interested. I don't know what I want to do. And so you have this variation, and decide for yourselves on these things. And certainly if there were an underlying medical condition that would be contraindicated, don't do it. But for the most part, that is one of the things that is out there that is on the fringe. But for the most part, you can't recruit eggs that are not there. You can't change the DNA of an existing egg. And so the question is, what can you do to improve it beyond that? Well, if there's only limited options for making the most of your existing eggs, then the next step is actually to get someone else's. And that's an egg donor. And that's someone typically where you're aiming for someone around 25 to 30. And again, you can go younger, you can go older, and not everyone older has bad DNA, and not everyone younger has a ton of eggs. There's variation, and you can be surprised. But that if you get a young person without infertility, you are more likely to have chromosomally normal eggs, and a lot to take from, to sample from. And so here's the thing: if you get 6 blastocysts from a person who's 25 to 30, previous fertility, you're often looking at about 2/3 of them taking. The way I describe it is heads are pregnant, tails are not. If you have 6 tosses of that coin, and again, it may be even better than that, you're looking at, again, at least 1 usually coming up heads, and on average 3 to 4. You can't guarantee this. The body doesn't always read the book, and you can be surprised. But ultimately, people who use donor egg, even if they have ovarian failure, do quite well. Moreover, with that, the embryos can freeze, and then you can use them for additional babies down the road after you're done. But on top of that, the risk of Down syndrome is that of the donor's age, not of the person carrying it. So you can give a 25-year-old's eggs to a person who's 40. The risk of Down syndrome is that of a 25-year-old, not of a 40-year-old. So there are all kinds of advantages that can work out well for this. And again, if you are 25 or 45 and taking donor eggs, the difference is 1-2%. It's very subtle. Most of whether it takes or not depends on the age of the donor, not your personal age. The differences between women who are in their 40s trying to get pregnant with donor egg relative to those in their 20s. Women in their 40s have had more chances for fibroids and other issues with the uterus where it might be less receptive. I'm going to catch up on comments for a lot of things.
Casey Ward,
yeah,
I'd love to hear your input on how people have precancerous cells, and Doctor wants to do hysterectomy.
Okay.
But wants to have another child. She's been trying for 5 years.
Okay. So first, I'm going to say, there's so many awesome people here that I want to say hi. Christy, Casey, hi, all you guys. Okay. So I'm just quickly quicking for things. So the precancerous cells. So first, I would say for precancerous cells, hey, Rachel, hey, Brandy also. For the precancerous cells, the answer that's always right in medicine is it depends. So it depends on how bad the precancerous cells. You can have abnormal paps, and people get those all the time, and that's just something while you watch it for a bit. And then you can have, let's say for cervical cancer, which is what a lot of people talk, CIN 1, 2, or 3. The data that I recall for it, and again, I'm not an oncologist, so this would have to be confirmed, but for CIN1, if you ignore it for 10 years, you have a 1% chance of it progressing to full cancer. CIN2, 4%. CIN3, I would say 9%. You take 1 or 2 or 3, and then you square it and it gets to 9%. It's really about 11%. But the point is, the higher the number, the more likely it progresses to cancer. But that's if you ignore it for 10 years. There are often things where you can remove part of the cervix through, if it's a cervical cancer, again, LEAP procedure or cones or other things like that. And then also for endometrial cancer, there also are hormonal therapies that you can give for pre-cancer cells like endometrial hyperplasia with or without atypical. The number one thing I would be thinking about is if you have precancerous cells and are still wanting another child, you should talk with both a fertility specialist and a gynecologic oncologist or someone who specializes in precancerous treatment. Because the thing is, yes, nobody wants you to have cancer and nobody wants it to progress, but often if you have a long timeline where it's unlikely and there are things that can be done to further treat you or reduce those odds, figure that out first before saying, I've had a hysterectomy and now my options are cut off. And with precancerous cells that have been identified, there's a lot that can be done to confirm, and there's a lot that can be done to communicate, and usually you have not just a month or even years. Now, again, that depends, and I say this without knowing anyone's diagnosis or anything, and you got to figure it out. But communication with experts before you make definitive, irreversible decisions that often have a little more time to think about, that's a good balance for things. And so, yeah, we have people right now who are treating who've had precancerous cells, both for the cervix as well as for within the uterus, and we're planning for them to get pregnant. We've had people who've had cancers even that have been treated and that are going on to become pregnant. But it's all about the right balance of risk and benefit, and it's all about communicating and understanding properly what's going on. Okay, how can you make, from Jessica, I would love to hear on how you can make eggs without having a menstrual cycle or even conceive. Now, so here's the thing. Making eggs without a menstrual cycle, the body makes eggs all the time. The question is whether you're ovulating. And so there's this constant turnover, and can you get them before ovulating? There's some complex stuff for in vitro maturation that you can do that, but that's sort of rare and fluke and sort of on the fringe. The broader thing is, for people who don't have regular cycles, can they get pregnant? And I remember a patient, this is from a decade ago, where she'd gone years without a period. So she'd actually been a meth user in her teens, cleaned her life up in her 20s, and in her 30s was finally ready to have a kid. And she never had periods. And when we scanned her ovaries, there were no eggs in there whatsoever. And I told her, there's a lot we can do, but I can't recruit eggs that aren't there. And but the interesting thing is, it wasn't that there were no eggs, it was that there were almost none, and most of them would break down. But there was one time about 7 months after that where, even though there was not much we could do for therapy other than give someone else's eggs, she was having sex, and an egg happened to be released, it happened to be normal, and she got pregnant. And the reason is, ultimately the menstrual cycle comes after ovulation, not before necessarily, for people who are very, very irregular. And she released an egg and it was there. You never say in fertility that someone will get pregnant or that they won't. You can only talk about whether something's possible or probable for things. So it's all about the odds. I always love that. One of the valuable things I do is give people a realistic sense of probability. I believe the lottery to be a tax on people who failed math. There is more money that comes out of it to the states than is ever given back to the people who pay for it. So ultimately, on average, you lose money with it. Now, again, there are reasons to do it. I've bought tickets before in my life. I get it. But the thing is, there's always a bit where we're sort of saying, it could happen. And the way I describe it is sort of like that thing from Dumb and Dumber, where you're saying, so level me with, what are my chances? Not good. Not good like 1 in 100, more like 1 in a million. So you're saying there's a chance. We get that for a lot of what we do for fertility. And we have to be able to say, what are those realistic chances? And if you are not reliably releasing eggs, the likelihood of conception is exceptionally low. You can do IVF, you can get them out, you can do things where you can try to jumpstart it, and you can give birth control pills quiet down the ovaries, and then this is more for PCOS, and then all of a sudden an egg is released. There are things that can be done with it, but for the most part, doing things in the typical way, doing things in the efficient way, where you're giving medications to stimulate the ovary, that's where you get your highest yield. And again, it's not can anything be done randomly. It's how do you do it in a way that's reliable, that's economically efficient, that's fast, and that's successful. And that's kind of the art. Let me just see for a few other comments for anything like that. Hey, Rachel.
Casey Ward, going back to you.
Oh, yeah. So technically, for CIN3, and then there's, this is something that it starts getting too specific for you. I'd love to speak one-on-one, but I can't give medical diagnosis over the internet and everything like that. Okay. For Chrissy, but that's a really important question. I'd love to talk more about that, but I would say that also is something I would incorporate a gynecologic oncologist for that decision. But I'd love, yes, call, let's talk, let's meet. There are things that can be done for addressing that. For Chrissy, great question. So the maximum age to be a recipient of eggs from a donor. So we'll say, here's what's official, here's what's unofficial. The normal cutoff is 50. Now, for someone who, if you look at someone who's really unhealthy, you might have to lower that number. You look at someone who's normal, you can say someone is, you can go 250. Someone who is exceptionally healthy, there are arguments made that you can go up to age 55. I think women are more than just their age. I think people are not just a number. I will admit that right now we have someone who's currently pregnant at 51. And so the thing is, but she received the embryos at 50. So there is a range. I think we have to see where an individual is, and I'm not going to violate HIPAA in giving you a personal answer or anything like that, but I will say that there are opportunities and there's some flexibility for some things. Other questions for anyone? I'm just going to do a last, I think a little bit, I've gone off a little bit for the eggs. Well, again, donor egg is still getting into a little bit of that for the Easter egg thing. Give me any last questions before signing off. The other thing I'd say for the eggs is just really knowing where you are, again, for your own balance of safety and success. If you are young, you need fewer eggs in order to be successful. As you start getting into the mid-30s, you have to start getting 2 or 3 eggs often to find one that's normal, and even 4 eggs as you hit to 40. There's a lot more room to be assertive as you get into your later 30s, but I still see that as young. Again, my wife turns 48 this year, and if I said that late 30s were old, she'd shoot me. But at the same time, I think that there's a lot more to wellness, fertility than just a person's age. One last comment checking here, and I think we'll wait. Okay, have the baby dust coming from everyone. Will weight problems cause fertility? Yes and no. That'll be the last one that I'm going to answer for today. So here's the thing. You go to any McDonald's, you will see there are hundreds of people. They're surrounded by a litter of kids. They're eating horribly, and it didn't seem to slow them down at all. The fact is, just because you have a particular frame doesn't mean you will or you won't get pregnant. Now, you can see where there are extremes of weight, where you can see where you're not releasing an egg, and your own genetic predisposition is if you have too little or too much that you don't ovulate. Yes, if you're not ovulating, it's really hard to get pregnant. But the thing is, when you look at, everyone is telling you this advice, which is saying you lose weight and then you'll get pregnant. Now, first, if that depends if it's the ovulatory or egg issues that is causing you not to get pregnant. You get the perfect figure, and I don't think there is a perfect figure. I think the perfect figure is the right one for you. But if you got some California definition of what you should be and you lost 50 pounds, if it won't fix things if the guy has no sperm. You lose 30 pounds. it won't fix things if your tubes are blocked. So all this stuff that people are saying for losing weight often doesn't make a difference for things. The next thing with that is that we've got someone coming here for a second. Cindy, could you check for a second? The other thing with that is that it's not just for your fertility. I'm sorry, I got someone coming in. I'm going to probably have to cut this broadcast short for a second, but the last thing on the weight for it is that if you look at being a BMI of 30, so body mass index where your height and the weight ratio is around 30, it's a calculation you can put in online. You usually see about a 5% slowing of your fertility, and as it gets to 40, it's about 10% by a lot of data. Those are really subtle changes. That doesn't make or break most people. There usually is something underlying that matters far more than just a person's dress size. And so don't beat yourself up. Things in moderation, be well for its own sake. I want you to have a healthy pregnancy and be around a long time for your kids by having eaten well. But then also, everyone who's telling you that it's weight, usually in most people I see, it's not the weight driving things. Okay, for last thing, I can get about having a problem keeping it past 2 months. That's something that we always would want to talk about because there are ways of working that up. I think we've done some broadcasts on that. We will do that another time. And then for AMH of 1.3, I do not consider that DOR. In fact, I have a lot of people who would kill to have an AMH of 1.3. So I would say that definitely has to be, I want to see what someone said to give that sort of diagnosis, but 1.3 is better than a lot of people for an AMH. Thank you guys for all tuning in. Come up with more questions for me. You can post it later. We'll scroll through. We'll do that in the next one. I haven't figured out the May topic. The May topic may end up being related to hysteroscopy. I'm flying to Barcelona for the Global Hysteroscopy Conference and going to be one of the speakers there. And finding out the latest and greatest for how to understand the inside of the uterus. So I might end up doing some highlights on that, but we'll also take any questions all of you guys have. Have a wonderful Easter. Come to our reunion. I love seeing all of you here, and thank you and God bless.